Hello, everyone. Welcome to Cracking Addiction. My name is Dr. Ferghal Armstrong, and we're talking with the good Dr. Bradlow today. Hello, Rich. I thought we'd have a little chat today about the assessment and the risk for alcohol withdrawal, and also the identification of alcohol withdrawal. So, firstly, the assessment. So, I think it's important to emphasize that not everyone who drinks alcohol is at risk of alcohol withdrawal. So can we talk about the diagnostic differentiation of that?
Absolutely. Thank you very much for having me today, Ferghal. It's a pleasure to be here. When I am assessing someone for alcohol withdrawal, I look at, the number one question that I have is, how much do you drink? Do you drink every day? And what happens when you stop drinking? And I think that third one's very important to emphasize, because everyone has a different alcohol withdrawal pattern, and that pattern tends to be specific to them. E.g., if you have a history of seizures, you will likely have a seizure next to alcohol withdrawal. If you don't, you will likely not.
Well, I was going to say, that the previous history is absolutely essential, isn't it? And, theoretically, people go into alcohol withdrawal. If you're dependent on alcohol, people go into alcohol withdrawal every night they sleep. But here's a question for you. How do you categorize the people that, come home, they do a hard day's work, they come home, they treat themselves to a bottle of wine, and then they go to bed slightly intoxicated, and they get up and, a bit groggy, but then they get to work, they go through a really terrible day at work, full of stress, and they come home, and then again, they treat themselves to a bottle of wine. How would you diagnose that kind of consumption?
Yeah, well, this is tricky, and it's constantly shifting. So in previous times, people would have said use diagnoses such as harmful or at-risk use of alcohol. But under the current DSM, that would be alcohol use disorder. Perhaps it would be a more moderate alcohol use disorder. But I think, and what we're talking about today is when we're trying to analyze the risk of a severe withdrawal. I think, again, to go back, my most important question is, do you drink every day? Are you having that bottle of wine every single day? And what is it like on the day you don't have that bottle of wine? Because I think for a lot of people in that scenario describing, who certainly have an unhealthy relationship with alcohol and are certainly not drinking responsibly, are still not likely to be at risk of a severe medical complications of stopping alcohol. So I think to get into the more sort of nitty gritty, and it will depend for men and women. You want to know when you're starting to suspect a significant or potentially dangerous alcohol withdrawal. You're thinking at least 6 standard drinks if you're a woman, and 8 standard drinks if you're a male nightly. And I think for your example with the bottle of wine, that's 8 standard drinks, or nowadays, maybe 8.5 with certain.
Maybe 9 if it's a Rioja.
Yeah, so it is quite a lot of alcohol, and I think we can. And I personally have talked to a woman who was in liver failure, who had no idea that she was drinking dangerous amounts of alcohol, because when she got home from a day's work with her husband, they would share a strong G&T, and then they would have a bottle of red wine each. And the first time she knew she had a dangerous relationship with alcohol was when she got ascites and turned yellow and was in liver failure. So, but we've made in this country, casual drinking very casual, but a bottle of wine's still quite a lot of alcohol.
Yeah. And I suppose this is a useful segue into what kind of guidelines are there for the safe consumption of alcohol?
Absolutely. Well, the Australian government's been very, very useful to us and it's given us this guideline. Frustratingly, it changes.
Bradlow, do tell.
Frustratingly, it changes a lot, but the science is always changing. The advice would be no more than 10 standard drinks a week and no more than 4 standard drinks in one sitting.
No, that's something that I tell. We both tell our patients 10 and 4. It was somewhat challenging to realize that the Canadian guidelines actually suggest that to avoid all risk of alcohol-related harms, you're actually talking about 2 standard drinks per week. And moreover, the Australian guidelines give a kind of a dose risk relationship where they say that if you're drinking about 4 standard drinks a week, you're increasing your risk of certain cancers. And if you're drinking more than 6 standard drinks a week, you're increasing your risk of cardiovascular and cerebrovascular disease. So they've really honed in on the risks of alcohol to the point where really, if you're going to be true to your patients, you have to say really 2 standard drinks and or abstinence. That's the safest way forward, isn't it?
100%, I agree. But I've got a little trivia for you. What is the
All right.
Canadian standard? What is the Canadian standard drink?
That is a very good question.
No Googling, because I see you looking down at your computer.
Well, I can't tell you what the Canadian standard drink is. I can tell you what the US standard drink is, and I'm assuming it's the same. So, and this is another trivia for you, right? So in the States, the United States, 1 standard drink is actually 14 grams of alcohol, whereas in Australia, 1 standard drink is 10 grams of alcohol. Now, if we look at the Australian guidelines, and we say 10 standard drinks for a week, right? That's 10 times 10, so that's 100 grams of alcohol. Now, if you look at the American guidelines, they say for a man, 2 standard drinks a day, or for a woman, 1 standard drink a day. Now, if you're a man drinking 2 standard drinks of alcohol a day, and each standard drink contains 14 grams of alcohol, that's 196 grams of alcohol in the week, which is almost double what the Australian guidelines say is a safe limit for alcohol consumption, which even then is still, in my opinion, somewhat permissive. So, I mean, if you're talking about 2 standard drinks for the Canadian guidelines, I'm presuming it's 14 standard drinks, so it's 28 grams of alcohol. It's
13.45 grams of ethanol.
13.45.
Yeah.
Is that the same for the States?
No, well, I have to look. So I did cheat and Google before I asked you that question, because obviously I don't know the Canadian guides for ethanol. What defines a Canadian standard drink? I believe from memory that the UK standard, and this is without cheating, the UK standard drink is 8 grams. But I'm sure you're more on top of me.
I can't actually remember. I can't remember, but
I think what you're getting here is these are all guidelines. And they're stabs in the dark. And I think it is governmental organizations playing off the societal norm of drinking with what is now becoming more and more evidence that alcohol is not healthy for us. There's likely no safe amount of alcohol to drink. And I think that's what we're seeing is government organizations. If you just said, don't drink, the vast majority of the public is going to ignore you. And I think that's what they're trying to play out. I think if we're going to talk realistically, and I am someone that likes to responsibly drink, but if we're going to talk realistically, I don't believe there is a safe amount of alcohol to drink, full stop. And I think society would be sad if we were all teetotalers. But I don't see Oliver Cromwell coming back anytime soon, and thus we're going to have to stick with these sort of trying to mitigate the harms.
To my knowledge, I don't think he's going to come back to Australia if he were to come back. I think he did. Yeah. I think he did his most good in Ireland somehow. One wonders what's a standard drink in Ireland. I wonder. 50 standard drinks. I don't know. So please don't sue me. All right, where were we?
I think we were talking about at what level of drinking would you be concerned about someone's withdrawal?
Yeah. All right. Well, yeah. The Australian, as you said, the South Australian guidelines suggest 6 and 8, so 8 standard drinks a day for a man for 2 weeks and 6 for a woman, and that gives you that starts to put you into the territory of being at risk for withdrawal. But there are other characteristics. So psychosocial impairment as a result of alcohol, being homeless or being hospitalized, that will also put you at risk of alcohol and alcohol withdrawal, and also the complications of alcohol.
Absolutely. And I think that gets to, and you've talked about this on your podcast before, but when we talk about what defines addiction, there's the two physical symptoms of withdrawal and tolerance that are part of it, and the rest are all sort of what we call the salience symptoms of addiction, and that's the role alcohol takes in our life. And if someone is having psychosocial impairment from their alcohol use, it implies a more severe addiction. So what we're really still talking about there is the severity of the addiction. And I see that I was right. UK is 10 grams. And Ireland is 10 grams. So UK is 8 grams. Ireland is 10.
UK is 8 grams, and Ireland is 10 grams. So the little elves in the background are helping us through this morass. Yeah, I've from the depths of my temporal lobe, a little fact has bubbled up to the surface, and I want to say that roughly 5% overall of all the people who drink, 5% are at risk of withdrawal. But of those who reach hospital, up to more than 50% of people are actually at risk of withdrawal. Does that sound right to you, or have I just
honestly? I think to me that sounds it's a realistic number, but I would assume higher. I think about 10% of people consume about 80 to 90% of all alcohol. And I would imagine about 10% of alcohol users do have what we would define as a severe alcohol use disorder. And these are just numbers I'm pulling out of the side. I don't have the numbers to back me up here. This would be guessing. I think 5% sounds reasonable. That sounds like an underestimate to me, but it could be.
Yeah.
We should be looking this sort of stuff up before we
should really know this before we go on the live. Yes. Yeah, we should know this. Given that we call ourselves addiction psychiatrists or addiction specialists, it's something that should just trickle off the tongue.
Well, I can say that 10% of alcohol users do consume 80 to 90% of alcohol. So that's something. I would assume that 10% that is a fact. No, that is a fact. But unfortunately, that is a fact for most things.
You'd bet your mortgage on that, would you?
I would bet my mortgage on that.
Must be true.
Must be.
All right. So let's look at this in terms of being on the floor, the cold face, right? So someone comes into hospital. How do you diagnose alcohol withdrawal? What's your approach?
Yeah. Well, I mean, the most important is the patient or the client rather is the best expert on themselves. So often the easiest thing to do is ask the client, are you in alcohol withdrawal? Are these the symptoms of alcohol withdrawal you've had before? And they'll say yes, and that's a very easy diagnosis to make. But there are obviously so the way you think about alcohol withdrawal is what's happening is you've got an exogenous depressant pathway, and you've removed that. So now you've an endogenous sympathetic pathway that has been built up as a sort of as a opponent process to that exogenous depressant pathway. So what you are getting is overstimulation. So that'll come around with agitation, anxiety, tremors, insomnia. Physical symptoms of agitation, sympathetic overdrive, so tachycardia, hypertension, diaphoresis, and then on the more severe end of things, you can get seizures or hallucinations.
So I'm
sure you have a wonderful acronym for us, though, Ferghal.
Well, since you asked, I do have a very wonderful mnemonic. But before I go on to the mnemonic, right? I think about alcohol withdrawal as I think of it as presenting as a combination of autonomic hyperarousal and perceptual disturbance. So what does autonomic hyperarousal mean to you then?
So that's the sympathetic. That would be tachycardia, hypertension, tremor, diaphoresis.
Yeah. And then the perceptual abnormalities. How does that present in terms of alcohol withdrawal?
Well, I mean, the typical alcohol withdrawal hallucinations are little black things that you see on this. So not uncommon for someone to say, I see little black mice running around on the ground, little spiders, little black visual hallucinations. But the interesting thing about alcoholic hallucinosis is people can get it mid-intoxication as well. So it's not a syndrome limited to withdrawal. And it can go on for a very long time, well after what we'd understand is the physiological withdrawal is over.
Yeah. So that refers to, I mean, you know, we used to think about the pink elephants, you know, the alcohol use disorder was associated with seeing pink elephants. And so that refers to the alcoholic hallucinosis. So really for me, if you really want to break it down very simply, there's only two symptoms of alcohol withdrawal. It's the autonomic sympathetic hyperarousal, as you've already described, and that range of symptoms, and then the perceptual disturbance. But you have to fit that into the context. So there has to be a history of alcohol consumption such that it would put you at risk of withdrawal. Then there has to be a sudden reduction or cessation of that alcohol. Then you have to have those symptoms, as we've discussed. And then you have to exclude differential diagnoses. And that's where it gets tricky, isn't it? Yeah. That's a big one.
Before we say something useful, we say something useful, I've got a bit of useless trivia for you. You say pink elephant. A beer that has won the award for the best beer in the world is called Delirium Tremens, and its symbol is a little pink elephant. It's a Trappist monk beer made by some Belgian monks.
Yeah.
The little pink elephant. It's called Delirium Tremens, which is a wonderful fact. But now I've forgotten the question. The question was, how do we exclude other
the differential diagnosis? Because alcohol withdrawal really can present, or there are many, many other possible diseases and disease processes that can look like alcohol withdrawal. And when you have someone with a history of alcohol consumption in front of you, it's very, very easy to blame it. Oh, it's just the booze. And that's not good medicine.
Absolutely not. And that is a very tricky thing. Generally, what I like to do is rule out red flags and work from a sort of a hierarchy of diagnoses to make sure I'm not missing something. That's especially important when we're talking about when someone's in severe alcohol withdrawal, like delirium. Yeah. We need to make sure that, I mean, that's a life-threatening illness in itself, but you need to, so take a thorough history, take a collateral history, make sure they don't have any sort of life-threatening illnesses, make sure you get a decent pathology, make sure you get necessary investigations. I think, unfortunately, when we're talking about something as so broad, someone's coming and presenting with delirium, it could be a million things. I think often your role as addiction specialist is advocating for an adequate job to be done by a physician, rather than taking on that role yourself. Maybe getting in there and say, I'm concerned about this. Would you be concerned about that? I often like to ham up the fact that I'm not a physician and I'm at their feet of genius when they're trying to dish off their patient to me.
Have you considered an alternative? Have you considered this? Have you considered that? Yeah.
So I'm just a lowly addiction psychiatrist. Perhaps your wisdom and genius could fix this.
Have you considered this vast differential diagnosis? So in my mind, I think about gastrointestinal bleeding, overdose, trauma, head injury, hepatic disorders, infections, meningitis, pneumonia, urinary tract infection, even, and metabolic disturbances, salt abnormalities, potassium, sodium, a huge wide range of things.
This goes on. Arrhythmias, it's because it's such a broadly presenting.
What else goes on?
That it could be quite a lot.
Yeah, yeah. All right. So I know you've asked me for the mnemonic. So let's go back. This is my mnemonic for the symptoms of alcohol withdrawal. Now, remember, you have to assess alcohol withdrawal in terms of that rubric. So there has to be a history of heavy alcohol consumption. There has to be a history of cessation or severe reduction. And you have to exclude everything else. So I use the mnemonic past night, which alludes to the fact that you had a really heavy drink last night and now you're in withdrawal. So past night. So P for psychomotor agitation, A for anxiety, S for seizures, T for terrors or transient hallucinations or illusions, N for nausea or vomiting, I for insomnia, another T for tremor, and E for excitability, i.e. autonomic excitability. So let's look at some of those definitions. Psychomotor agitation. What is psychomotor agitation?
That's tremor. Sorry, big pardon, it's not tremor. It's sort of often presents with leg shaking, pacing, feeling of uncomfortableness, wanting to move about, feeling that classic overdrive of wanting to move. Your
Yeah.
sympathetic nervous system firing off.
Yeah.
Don't want to sit
Someone who's
still.
not able to sit down quietly and have a cup of tea and a chat, you've got to chase them around the room.
Or the leg tapping and tapping the knee tapping the table.
Yeah. Yeah. I have that all the time, mind. But I don't drink. So seizures. What kind of seizures do you get in alcohol withdrawal?
Yeah, the seizures in alcohol withdrawal are grand mal as an alternate. So you should lose consciousness. They should be full body. There should be tonic-clonic seizures. Typically, they're short-lasting, 30 seconds to a minute.
Yeah.
And they peak in intensity at 24 hours of alcohol withdrawal. So 24 hours since your last drink. Unlike sort of the rest of the alcohol withdrawal symptoms, which peak 3 days, so 72 hours since your last drink. But again, having said that, everyone's alcohol withdrawal follows an idiopathic pattern. So if I've talked to people that say, when my blood alcohol reaches 0.005, I have a seizure. So you need to start medicating me before then. I have other people that say, I have a seizure on day 4. That's just what happens to your body. So everyone has their own alcohol withdrawal. And the patient is, as always, the expert on themselves.
Yeah. So really, you got to listen to the patient.
Absolutely.
Mm-hmm. Rich, we're running out of time today, but I think we have covered the diagnosis of alcohol withdrawal and the risk for alcohol withdrawal. And I think we've established that you can have a drink and not be at risk of alcohol withdrawal.
I hope so. I think what I want to leave everyone with today is, I think this is my handy that I've stolen actually from Mike Tedeschi, who's an addiction med specialist in Canberra. But this is my handy. The audience here is junior doctors, GPs. The number one question you want to ask someone when you're dealing with alcohol withdrawal is one question: is what happens when you stop drinking? They'll tell you straight up. And that is the very first question I ask everyone.
On that sweet note, Dr. Richard Bradlow, thanks for your expertise. We'll see you next time.
Thank you for having me.
That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.